If you've swallowed the same blood pressure tablet every morning for the last year, Amlodipine, Losartan, or Lisinopril, ask yourself honestly, do you actually know what that pill is doing inside your body right now? Not the line on the pharmacy label, not the one sentence a rushed pharmacist read off a printout. I mean, really understand it, how it works, how it can turn against you under the wrong conditions, and which warning signs separate a harmless side effect from a genuine emergency. Most people I talk with, sharp, capable people who manage their own bills and keep up with the news, go quiet when I ask that question. That pause tells me everything I need to know. Because these are not gentle medications, they are not vitamins. Amlodipine, Losartan, and Lisinopril all reach into the way your heart, your blood vessels, and your kidneys function every single day, all day, and yet countless older adults take them purely on autopilot, with almost no sense of what to watch for, what to avoid, or when an ordinary symptom is actually the body waving a red flag. My name is Dr. William, and this channel, Senior Medical Insight, exists for exactly this reason, to hand you the clear, practical, honest information that a rushed 10-minute appointment rarely has time for. By the end of this, you'll understand these 3 medications well enough to feel safer, steadier, and much harder to catch off guard. Let me start with a story that sets the stage for everything else we're going to cover, the story of a man I'll call Harold. Harold was 74, a retired engineer, precise about everything in his life. He never missed a dose. His daughter had set up a labeled pill organizer for him, and he treated it like a project schedule. When his doctor added amlodipine to his routine, Harold assumed it was simply another blood pressure pill. Same job, different name, nothing to think twice about. That assumption cost him a difficult few months. 3 months in, Harold's feet had swollen so much his regular shoes no longer fit. By late afternoon, his legs felt thick and heavy. He began cutting back on walking because moving made it worse. Quietly, he started to fear his circulation was failing, and he began searching online for heart failure symptoms. The real explanation was far simpler and far more manageable. Nobody had ever told Harold that amlodipine, Losartan, and Lisinopril, despite all lowering blood pressure, are not variations on the same drug. They belong to 3 separate families, and each one interacts with the body differently. Amlodipine is a calcium channel blocker. It relaxes the smooth muscle inside your arteries, so blood moves with less resistance. Lisinopril is an ACE inhibitor. It blocks an enzyme responsible for tightening blood vessels. Remove that tightening effect, and pressure drops. Losartan is an ARB, an angiotensin receptor blocker. It acts on a similar system to Lisinopril, but through a different entry point, and that difference matters more than most people assume. 3 mechanisms, 3 different side effect patterns, 3 different things to watch for. Once you understand that, you stop reading every new symptom through the same lens. Harold's swelling wasn't heart failure. It was amlodipine doing precisely what it does in a meaningful share of the people who take it. Relaxing the arteries, feeding the legs, more than the veins draining them, which lets fluid pool in the lower legs. Once identified, it was addressed, and Harold was back in his walking shoes within weeks. The name on your prescription bottle isn't just a label, it's a category, and the category tells you the pattern to expect. Let's go deeper on that swelling, because it's one of the most misunderstood side effects in blood pressure medicine, and it affects a striking number of people who take amlodipine. Here's the simple version of what's happening. Amlodipine relaxes the small arteries carrying blood into your legs, so blood flows in more freely. But the veins responsible for carrying blood back up toward your heart don't loosen in the same way. That mismatch, more blood arriving than leaving, builds pressure in the small vessels near your ankles and feet, and eventually that pressure pushes fluid out into the surrounding tissue. The result? Puffy ankles, sock lines that dig in, shoes that suddenly feel tight, legs that feel heavy by the end of the day. This is not salt-driven fluid retention. It is not your kidneys failing. It is not the beginning of heart failure. In most cases, it's simply a predictable mechanical response to how the drug works. Here's where it turns genuinely risky, not the swelling itself, but how people react to it. Some quietly stop the medication on their own without telling anyone, and their blood pressure creeps back up while they believe they've made a sensible call. Others keep taking it but start cutting back on water, assuming they're retaining fluid, which is exactly the wrong instinct, since dehydration carries its own dangers on this class of drug. And some, like Harold, simply endure it in silence for months, scaling back their activity and assuming the worst. The right move is simple. Leg swelling on amlodipine is a conversation for your doctor, not a decision to make alone. Not because the drug is wrong for you, but because there are usually adjustments available, elevating your legs, changing when you take the dose, or in some cases switching medications entirely. None of those options exist if you suffer through it quietly. Now let's talk about lisinopril and the most well-known side effect in the ACE inhibitor family, the cough. Not wet, not productive, a dry, scratchy, persistent tickle in the throat that tends to worsen at night and shrugs off cough drops, antihistamines, and anything else in the medicine cabinet. What makes this one tricky is timing. It doesn't always start right away. Some people develop it within a week, others take 3 or 4 months, by which point the connection to their medication never crosses their mind. They've already been taking the pill without issue for months, so instead they blame allergies, dust, or a lingering cold. I want to tell you about a woman I'll call Marion. She was 71, an enthusiastic gardener, and when her cough began one spring, she assumed it was simply pollen season. She tried antihistamines. She bought an air purifier. Her family doctor even ordered a chest X-ray, which came back clear. 6 months later, the cough was still there. Her sleep was in tatters most nights, and she was starting to worry something serious had been missed. When she came to see me, one of my first questions was simple. When did you start lisinopril, relative to when the cough began? She paused, checked her phone, and worked out the timeline. She'd started the medication 11 months earlier, and the cough had appeared around month 4. She had never connected the two. Once we made the connection and, together with her regular doctor, switched her to Losartan, which works on a similar pathway but doesn't tend to cause this cough, the tickle in her throat disappeared within 2 weeks. 11 months of disrupted sleep, resolved in 2 weeks, the moment someone connected the dots. Now here's the part I need you to hold on to separately, because it isn't a nuisance, it's an emergency. If you're on lisinopril and you notice swelling of your lips, tongue, face, or throat, especially if breathing or swallowing becomes difficult, do not wait. Don't call the office tomorrow. Don't take an antihistamine and see how it goes. Call emergency services immediately. This is a reaction called angioedema. It's rare, but it's real, and it can close off an airway faster than you'd expect. A dry cough is an annoyance. Throat swelling is an emergency. Please keep that distinction clear in your mind. Let's move to Losartan, and a risk I find especially striking because it usually doesn't come from someone doing something careless. It comes from someone trying to do the right thing. Losartan, like lisinopril, works on the body's blood pressure regulation system, and one side effect of that whole drug class is a tendency to raise potassium levels in the blood. For most people, that stays within a safe range when it's being monitored, but add certain everyday habits on top of it, and the picture can shift. Here's the counterintuitive part. Potassium doesn't only come from bananas or supplements, it's hiding in products marketed as the healthier option, salt substitutes. Many popular low-sodium alternatives sold right next to ordinary table salt and often labeled heart-healthy simply swap sodium for potassium chloride. So picture someone who's been told to cut back on salt, switches to a potassium-based substitute, and uses it generously on every meal, all while taking a medication that already nudges potassium upward. The combination can push potassium high enough to interfere with the heart's electrical rhythm. What makes this dangerous is that elevated potassium often doesn't announce itself loudly. It can show up quietly as unusual muscle weakness, persistent fatigue, cramping in the legs, tingling in the hands, or an irregular, fluttery heartbeat. And sometimes there are barely any symptoms at all, right up until there are serious ones. If someone in your life, maybe you, has switched to a salt substitute in the past year or two while taking Losartan or Lisinopril, that's worth a conversation with a doctor. Not because the medication is unsafe on its own, and not because potassium-rich foods are a problem by themselves, but because the combination, without any monitoring, can build into trouble that never needed to happen. Electrolyte powders, some meal replacement shakes, and certain sports recovery drinks carry meaningful potassium loads too. And because they're not prescription items, nobody thinks to mention them. That's exactly why they matter. Here's a scenario I don't think gets nearly enough attention, and it affects older adults more than any other group. What happens to these drugs when you come down with something ordinary, a stomach bug, a few days of vomiting or diarrhea, a loss of appetite, or even just a hot week with heavy sweating and not enough fluids? When your body is dehydrated for any reason, the same dose of Losartan or Lisinopril that was well calibrated for a well-hydrated body can behave very differently. Blood pressure can drop further than expected. Kidneys, already working harder because of the fluid loss, become more vulnerable. Dizziness, weakness, faintness, or even acute kidney strain can develop faster than most people anticipate. The medication hasn't changed. Your body's internal conditions have, and the drug is now operating in circumstances it wasn't calibrated for. This is one of the most useful things I can tell you today. Illness changes the rules. If you don't already have a plan for what to do with your blood pressure medication when you're sick, whether to hold a dose, when to call your doctor, what symptoms should send you in, that's a real gap in your safety net. Ask your prescribing doctor for that plan before you ever need it. What should I do with my blood pressure medication if I get a stomach virus or can't keep fluids down? It's one of the most important questions you can ask and one of the least commonly asked. Picture this. Your arthritis flares up, your knees ache, your back is stiff, so you pick up an over-the-counter anti-inflammatory ibuprofen or naproxen, something you've used for years without a second thought. Now add Losartan or Lisinopril to the picture, and perhaps a diuretic on top of that for fluid management. Used regularly, this combination can meaningfully reduce blood flow to the kidneys, and in the context of even mild dehydration, the risk of kidney injury rises substantially. This isn't a rare hypothetical day. It's one of the most common, most preventable situations I encounter. And it slips through because people don't think of over-the-counter anti-inflammatories as real medications in the same category as a prescription. They're just something from the drugstore shelf. But your kidneys don't distinguish between prescription and over-the-counter. They respond to chemistry. If you regularly reach for anti-inflammatory pain relievers for arthritis, joint pain, or back pain, and you're on any of these 3 blood pressure medications, that's worth raising with your doctor. There are often safer alternatives: acetaminophen, topical treatments, physical therapy, that don't carry the same kidney risk. You don't have to simply tolerate the pain, and you don't have to quietly accept the risk either. One more thing, and it sounds minor. It isn't. That brief wobbly moment when you stand up from the couch or get out of bed, the world tilting for a second before it passes, and you write it off as got up too fast. For many older adults on blood pressure medication, this happens regularly, and it's almost always underreported because it feels too small to bring up. Here's why it matters. In older adults, a few seconds of dizziness is enough to cause a fall. A fall is enough to cause a fracture, and a fracture, a hip fracture especially, can derail someone's health for years if they fully recover at all. That's not scaremongering, it's simple physics and biology. The dizziness happens because the medication is doing exactly its job, lowering blood pressure, and when you stand up quickly, your circulatory system hasn't had a moment to adjust. Blood pressure dips briefly, blood flow to the brain drops for a second, and you feel that light, tilting sensation. The fix is usually simple. Rise slowly, sit at the edge of the bed for a moment before standing, hold on to something stable as you get up, and give your body a few extra seconds to catch up. But dizziness that happens often, that doesn't ease after the first few weeks on a medication or any near-fainting episode, deserves a real conversation with your doctor. The dose or combination of medications may need a second look. Here's one that surprises almost everyone I mention it to. A simple bowl of grapefruit or a glass of grapefruit juice at breakfast seems like the healthiest possible way to start the day. For most people it is. But if you're taking amlodipine, it can quietly change how much of the medication actually reaches your bloodstream. Grapefruit contains compounds that interfere with an enzyme your gut and liver use to break down certain drugs, amlodipine among them. Interfere with that enzyme and less of the medication gets cleared the way it normally would, which means more of it stays active in your system than your prescribed dose was meant to produce. In practical terms, that can mean a stronger drop in blood pressure than intended, along with a higher chance of the ankle swelling and dizziness we've already talked about. This isn't true of every blood pressure medication, and it isn't true of every citrus fruit. Losartan and Lisinopril aren't affected the same way. But if grapefruit has been part of your morning for years and you've recently started amlodipine, or if you've been on amlodipine for a while and only recently added grapefruit to your routine, that timing is worth mentioning to your doctor or pharmacist. It's a small detail that rarely comes up in conversation, and precisely because of that, it's exactly the kind of thing worth asking about directly. One more piece worth understanding. Very few people managing blood pressure in their 60s, 70s, or beyond are taking just one medication. There's often a cholesterol pill, something for blood sugar, maybe a blood thinner, an antidepressant, a supplement recommended by a friend. Each one individually might be perfectly reasonable. Stacked together, without anyone reviewing the full list at once, the picture can shift. This is why I always encourage patients to bring every single bottle to at least one appointment a year, not just the ones that feel important. Vitamins, herbal supplements, anything from the pharmacy aisle that isn't technically prescribed. A pharmacist or physician looking at the complete list side by side can catch overlaps and interactions that are invisible when each medication is only ever discussed on its own. This single habit, reviewing everything together rather than piecemeal, prevents more complications than almost anything else I can recommend. Last thing, and it matters more than people realize, blood pressure is not a fixed number. It shifts constantly through the day based on sleep, caffeine, pain, anxiety about the reading itself, a recent walk, even talking right before the cuff goes on. One high reading on a rough morning after bad sleep doesn't mean your medication has stopped working. One low reading after a hot, underhydrated day doesn't mean it's too strong. What actually matters is the pattern over time, measured consistently, same arm, same time of day, after a few quiet minutes of rest. When people track inconsistently and react emotionally to single readings, the decisions that follow rarely help. An extra dose taken out of fear, a skipped dose because one number looked good, an anxious call to the doctor about a reading that, in context, was completely unremarkable. Monitor with a method, track the pattern, bring the log to your appointment, and let the trend, not a single alarming number, guide the conversation. These medications work by maintaining a steady, consistent presence in your system, not through spikes and gaps. They are not rescue medications, and they were never meant to be taken reactively, the way you might take a painkiller only once a headache starts. Understanding how amlodipine, losartan, and lisinopril actually work, not just that they lower a number on a cuff, is what turns a passive routine into an informed one. That knowledge is the difference between quietly enduring symptoms for months, the way Harold and Marion did, and catching them early, addressing them, and getting your life back within weeks instead. Senior Medical Insight.